Good evening, everybody. I'm Dr. Soumya Kasturi. On behalf of Wincars Group, we are conducting this e-class today. The topic being basics of pediatric cardiac catheterization along with hemodynamics and basic angiograms. The topic will be discussed by Dr. Deepa. She is the additional professor from Chitra Institute of Medical Sciences. And the panelists are Dr. Snehal Kulkarni from Fortis Hospital, Mumbai, and Dr. Anand Subramaniam from Jaideva Hospital, Bangalore. These three are the people who directly and indirectly have taught me. So I learned a lot from them. So hope the postgraduates also will learn a lot. Along with me, there are two other panelists, Dr. Sujata and Dr. Anupam. So this is basically a session for postgraduates. So whoever has any questions, we encourage them to write the questions in the chat box. Right. So let's start the session. Over to you, Dr. Deepa.
Good evening. So I meant it as a truly interactive session. So anyway, please feel free to interact. You can put your questions and your comments in the question and answer. So let's start. So you'll have a lot of questions when I'm presenting. Basically, it was, as I mentioned, it was meant as a interactive session. So let's just start off with the basics of angiography in doing cardiac catheterization in the pediatric age group. So some basics, we should always go with an idea of limiting contrast as much as possible. So ideally, we should limit to 4 ml per kilogram per cath. Maximum, we can go up to 7 ml per kilogram. We usually use a flow rate of 1 ml per kg per second. We can increase it to 1.5 ml per kg per second, especially in shunt lesions. And of course, we can also use biplane to reduce both the contrast as well as the radiation. So just coming to the usual routine views that we use in...
Deepa, can I just interrupt you for 1 minute?
Yes.
Like Asbini, it's a good thing like you mentioned about the contrast. One of the practice we do is sometimes we dilute the contrast, because in a small 4 kg, 5 kg, the contrast total cannot be more than like 25, 30 cc's.
Yes.
And if you have like something like pulmonary atresia, then we know that we require a lot of dye for angio. Sometimes I dilute it like in a 30 cc dye, I may add another 15 cc.
Yes.
So we can have a little higher limit for a contrast use.
Yes, this is especially important when we are doing newborn interventions. We can use 1:1 with saline and contrast, or even lesser amount of contrast diluted with saline. Yes, ma'am. So these are the views that you have to remember, that when we are trying to profile a ventricular septal defect, whether it is for device closure or to help the surgeon in finding out where the VSD is. So for if you remember LEO 60 cranial 20 resembles a parasternal long axis view in a echocardiography. So if you think of what VSDs you can see in a parasternal long axis view, the first thing that comes to your mind is of course perimembranous VSD. The second thing is muscular VSD. So both these VSDs you can profile in LEO 60 cranial 20. And if you want to profile subarterial VSD, by which I mean subpulmonic VSDs, you have to use a RAO with a bit of cranial. If you want to profile an inflow VSD, if you look at echocardiogram, you would probably be using an apical 4-chamber. So the view that is similar to an apical 4-chamber is a LEO 40 cranial 30 to 40 view. That is to profile the inflow VSDs. We'll just come to some examples. So this is an LEO 60 cranial 20 view, where you see the dye is being injected, the catheter is being passed through the descending thoracic aorta into the ascending aorta into the left ventricle, and you see that the dye is being injected into the left ventricle. Of course, when you do an angiogram for a large VSD, you have to use more contrast and you have to use more volume, more speed. So flow rate. So if you see aortic valve, so this is to the slide then.
Yes.
So by the direction of the dye that is flowing from the left ventricle to the right ventricle, we can see what part of perimembranous VSD we are actually visualizing. So perimembranous VSD with an inflow extension will flow downwards. If you see, it is flowing downwards direction. And if the perimembranous VSD has got a subaortic extension, you see that the dye is almost flowing horizontally into the right ventricle. This is a great implications when you're trying to do a device closure. So here, the first image, you have to be more careful about the tricuspid valve, whereas in the second image, you have to be careful about the aortic valve. So you have to be careful about the aortic valve here. Here you have to be careful about the tricuspid valve when we are doing a device closure. The next is a perimembranous VST with an infundibular extension. That is, it is extending towards the pulmonary artery side. So here you have the dye going superiorly. So these are all soft indicators. This is just to help you when you are dealing with device closures. This is another VST. You see that the direction of the jet is going down, and you see that the right atrium is filling with the dye. That means that this is an indirect Gerbert defect. The TR is probably the VST jet going through the defect into the right atrium. The next one is a perimembranous VST, which is partly closed with the septal tricuspid leaflet. You see the aneurysm formed here, and the dye is again going down. This is an example of a subpulmonic VST, which usually we don't do an angiogram because usually subpulmonic VST, when we diagnose in early childhood, we usually send for surgery to prevent RCC prolapse and aortic regurgitation. But nowadays, small subpulmonic VSTs are also sometimes taken up for device closure, in which case this is a view that you take. It is an RAO view, and you're nicely profiling the VST right underneath both the aortic valve as well as the pulmonary valve. So how do we profile a patent ductus arteriosus? If you see here, we have taken a aortogram in the lateral view, and we have profiled the VST. And actually, I wanted to ask the people who are watching what device they think it is, but I think they have to put it in the chat box. You can put in the chat box what device you think this is. It's an unusual device that is being used for a PDA closure. You find that this is a lateral view, and the injection has been made in the descending aorta, and you see the PDA, you see the arch, you see the main pulmonary artery, and you see the left pulmonary artery, and the PDA has been closed in the next image with a device.
What is this type of the duct? Can people write in the chat box?
Yes. That will give a clue as to what device has been used.
Can people write in the chat box what is the kind of a PDA this is? What is the type of the PDA this is? I hope people know the classification. We just wait for reply, or we keep on going deeper.
We can
These are some of the questions which are asked to like stimulate you to read.
Yes.
This is a, you know, that you are seeing that this is a long tubular duct and which has constrictions in between. Deepa, I don't see that.
Yeah, madam, actually, if I have to see the Q&A, I have to go off my PowerPoint. So maybe you can read out, madam, what is written in the chat box.
What I see, it's a long tubular duct, and I see some kind of a constriction at the pulmonary end. So there are A, B, C, D, E. Now E also, isn't it?
F as well.
E, F, not A, E, E, F, sorry, F also.
Yeah, I think one person has got it right. Someone has written it's a vascular plug.
Yes. Okay, so this is another PDA. So sometimes lateral view may not be enough. We may have to do a RA view also, especially if you're if it's a very large duct, you're not clearly profiling in the lateral view. Another indication is when you want to profile the aortic end of the duct, we can do an RA view. So lateral view gives a clear idea about the aortic end as well as the position of the LPA, the size of the LPA. But if you want a much clearer view of the arch of the descending aorta, you can do an RA view also. So this is a very large PDA, which was subsequently closed with this device. Can anybody guess what device it is? It is a symmetric device, as you can see. So a symmetric device that can be used to close large hypertensive ducts. Anand, if you can see the Q&A, I am unable to see it actually.
Yeah, I don't think there are answers for this yet.
Okay.
But I see that the Q&A is disabled. Somebody has written it's disabled. I don't know.
Okay.
No, we are able to see what they are writing, so they can write.
Okay.
Scammy person, can you ensure that the question and answer is not disabled?
Yes, Dr. Sujata, the Q&A is visible to me as well.
So this is a large muscular VSD device that has been used to close a PDA. This is what we resort to when we have a large hypertensive duct. Basically, it should be a conical duct. And then coming to other angiograms, so when you want to profile a pulmonary valve, when you want to do a balloon pulmonary valvotomy for a severe pulmonary stenosis, or you want to do any other pulmonary valve interventions, the two angiograms that you take are one in the epicranial view. The second view is the lateral view. So if you have a biplane, you can get both angiograms in one go. So if you can see the white shadow here, that is the doming, thin, compliant pulmonary valve. So in this pulmonary valve, you're very confident to do a BPV because you're more likely to get a good result. You see, it is a thin, pliable, doming pulmonary valve. You see the same thing in the lateral view as well. You see this pulmonary valve is doming and you have a post-stenotic dilatation of the main pulmonary artery, which is what you expect in a normal pulmonary valvular stenosis. Is my screen visible?
Yeah.
Okay. Sorry, that's why I went off screen. So if somebody can say what is the difference between, in the Q&A, if somebody can type what is the difference between what I showed earlier and what you see in the two images here. There are a lot of differences between the image that we saw earlier and the two images that we see here. You can appreciate that this is the pulmonary valve in this case, and here is the pulmonary valve in the second case. So what is the difference from the previous angiogram that we saw?
One person actually said in the infundibular, that is
Yes.
probably the first one is correct. But other ones they are
Yes.
saying no significant post-stenotic dilatation, and someone said the pulmonary valve. I think
Dysplastic is what they wrote.
Yeah, okay, that's good. So you're correct. It is a severe infundibular stenosis. You see that the pulmonary valve is not so doming as previously. So probably there is no valvar component to the pulmonary stenosis. There is only a severe infundibular stenosis. Here you see that there is no post-stenotic dilatation. That itself should give you an idea that it is probably not probably a dysplastic pulmonary valve. You see the leaflet thickening is not very visible, but what is very apparent is the supravalvular tethering. You see that the valve is tethered on the superior aspect in the MPA. So this, you are unlikely to get a good result for both these cases. Of course, the first one is primarily surgical. The second one, it's a dysplastic valve, and you may not get the good result that you get from a pure valvular pulmonary stenosis in a non-dysplastic valve. So if anybody can tell me what in which condition you get a dysplastic pulmonary valve, and what is the ECG finding in that particular condition?
Written Noonan short PR.
Okay, Noonan, but more than short PR. Okay, PR interval can vary more
One
than that.
left axis deviation.
Yes, northwest axis in a Noonan. That is that gives you a valuable clue that you're dealing with a not the usual kind of valvular pulmonary stenosis. So when you want to profile an aortic valve, you take the same view as you took for a perimembranous VSD. That is, you go for LEO 60, cranial 20. And once you've taken an angiogram, you have to assess the aortic valve morphology. You also have to see if there is a subaortic membrane. What is the relationship to the interventricular septum and the mitral valve? and how do the coronaries look like. So you get a wealth of information from doing an ascending aortic angiogram, as well as if you suspect a subaortic membrane, maybe you should go ahead and do a LV angiogram as well. So can somebody enumerate the findings that we see here? This was a sick infant with severe aortic stenosis. In fact, I think it was a newborn. So shall I go forward, or shall I wait for somebody to answer in the chat box?
You answered bovine arch.
Yes, very good, very good. Somebody noticed the bovine arch. Yes. Anything else?
Doming and reverse doming BAV with post-stenotic dilatation. Severe AS interrupted arch. Bicuspid valve with Prussian helmet.
Yeah, it's not interrupted. You can see a PDA because somebody had started prostaglandin for a duct dependent systemic circulation. This prostaglandin was probably what was keeping the baby stable while we are doing the procedure. You can see the PDA open and the PA filling. You see there is mild arch hypoplasia as well, and as noted correctly, there is a bovine arch. The valve is not at all opening well. It looks eccentric. Cannot be very sure about that. And you can see 2 coronaries from 2 sinuses.
And the aortic arch interruption, we can't expect it. The catheter is gone from below across to the arch of the aorta.
Yes, yes. We've gone retrograde. So when you want to profile an LPA, we can always remember LPA is LO view or lateral view. And RPA, if you want to profile, it is usually RAO view. And you can give varying degrees of cranial inclination as well. If you are unable to profile in plain LAO, you can always give some cranial inclination. So if somebody can describe from where the angiogram is done and what are the findings? So course of the catheter, where is the dye injected, and what are the findings?
VT shunt there.
VT shunt, someone says.
It is coming from the neck. So
I don't think that's the right answer.
Yeah.
No, but subsequently they said the Glen also.
Yeah, okay. So, in fact, you can see the dye filling the SVC, filling back into the SVC. So this is a bidirectional Glen where the right SVC is connected in an end to side manner to the right pulmonary artery. And where is the catheter tip? If you notice carefully, can you see where the catheter tip is? Catheter tip is actually lodged in the main pulmonary artery. You can see some antegrade pulmonary blood flow through the hypoplastic pulmonary valve. If you notice closely, you can see the pulmonary valve moving. You can see some negative clearance, so there must be some antegrade flow. You see a very well-developed, good-sized right pulmonary artery. But what has happened to the left pulmonary artery? The left pulmonary artery is very small. But arborization seems quite decent. You can see all the lobes are having branches, but the branches are small. So this is a hypoplastic left pulmonary artery. This is a what view? This is a lateral view, and this is a child who has undergone unifocalization. And unifocalization means we have connected the MAPCAS to the branch pulmonary artery and completed the intracardiac repair. So after unifocalization, most times we have to go in and deal with all the MAPCAS that have become stenotic, where you have tried to join them to the native pulmonary arteries. So the view is, so this is a stenting of the left pulmonary artery and all the MAPCAS that have been unifocalized to the left pulmonary artery. The view is lateral view. Okay, this is just to familiarize with the views that we use for different branch pulmonary arteries. You see the so much beading and narrowing of all individual branch pulmonary artery segments. It has been tackled by stenting as well as by balloon dilatation of all the individual branches. Okay. Would anyone like to comment on this angiogram? Anand, has anybody written in the chat box?
Not yet. Yeah, peripheral PS, someone says.
Yes, yes, very good. So what we notice here is that it's a worst kind of peripheral PS where the main pulmonary artery is small, the right pulmonary artery is small, the left pulmonary arteries are small, and all the segmental branches are small as well. So this is the worst kind of peripheral pulmonary stenosis. Both branch pulmonary arteries, segmental arteries, as well as the main pulmonary artery is small. So this is a right pulmonary artery angiogram. What is seen here? It's a very rare anomaly. We have passed the catheter from the IVC to the femoral vein IVC, right atrium, right ventricle to the RPA, and we are taking another check angiogram with a pigtail. And what are we seeing here? Something has been closed. Some communication from the right pulmonary artery has been closed. So any guesses to what it is?
Non-committal answer. Fistula.
Fistula, someone has written.
It's a fistula, but to which structure?
There are answers: AP window, right-sided PDA, RPA to LA. PA to LA fistula. So,
yes. Okay, so this is an RPA to LA fistula.
Yeah.
AP window, usually we take an AP view, we don't take an RAO view. And AP window also, usually it is to the left. It is to the left of the spine. AP view, and the device will be to the left of the spine. So here it is coming from the right pulmonary artery, and it is, of course, the most obvious answer is RPA to LA fistula. So these are two different kinds of coarctations. The first one is a infantile coarctation post surgery, where the child has had a recoarctation. So in a recoarctation, we always go ahead with balloon dilatation. This is a native coarctation. Where is the angiogram done in the second instance? How is where is the catheter passed?
written radial route.
Yes, okay. So here, the first one, we have gone retrograde from the descending aorta into the arch and taken an angiogram. In the second case, we have deliberately taken an angiogram from the radial artery because it is a very tight coarctation. It's an A2 coarct in an adult. So these are the two views that you take for coarctation. You take a plain LAO, some 40 to 50 inclination, and if you want further delineation, you take a RAO view as well. So an LAO view and an RAO view to supplement your imaging. This was meant as a question, interesting question. So if anybody can answer, this was a post-arterial switch baby. This baby developed ventricular dysfunction. At the first review visit, we noticed severe ventricular dysfunction, and the surgeon was quite worried because he knew that this baby had a peculiar coronary anatomy. So the surgeon wanted us to do a coronary angiogram to see if things were all right. Can you describe the finding here?
Single RCA. Single coronary RCA giving all branches, anomalous origin of left coronary from right cusp. These are the answers. Single coronary.
Yes. Okay. Single coronary. It is a single coronary. So how do we identify which is which? The anterior-most one, this is a lateral view. So the anterior-most one close to the spine is close to the sternum is the left anterior descending. The next is the right coronary artery, and the one that goes posteriorly is the left circumflex. So left anterior descending, RCA, and the left circumflex. So you can see a beautiful single coronary artery. So it was not a coronary issue, it was a pump issue. Now, when we do interventions in the newborn, we have to go in and do things very urgently, especially when you're dealing with a PDA stenting. So always we have to decide where the PDA is coming from. Especially in a PDA stenting, you have to know the anatomy of the PDA, and you have to be prepared to go in and do angiogram in a definite view. Even prior to taking puncture, you should be ready. Okay, so if you have a PDA coming from the base of right innominate, it looks much like a BT shunt, and you have to go from the femoral artery axis and take an AP view. AP view will more clearly delineate the PDA insertion into the branch pulmonary arteries with maybe a slight cranial inclination. So an AP view is usually used for a PDA coming from the base of the right innominate. So this is the PDA, and you have the branch pulmonary arteries nicely connected to the PDA. When you have a PDA coming from the DTA, like the PDA that is seen in a pulmonary artery saying that ventricular septum, I hope you can see the stent here. The view that you take is a lateral view, like for usual PDAs, like you do for an usual PDA before device closure. The same view, you can take a lateral view as well as you can take an RU view to complement it. You can see that the wire has been passed through the PDA, it has been stented, and the check angio is showing that the stent is flowing well. Now, the most common PDA that you find in a pulmonary atresia VSD situation is that coming from the undersurface of arch, where you have to go via axillary axis. And here you have to experiment with views. You have to use either some LU view or a RU view to delineate the PDA. When you want to deal with pulmonary vein imaging, initially you can start off with AP. Whichever pulmonary vein, you start off with an AP view, and if you want to see the left pulmonary vein, you go to LAO or lateral. If you want to see the right, can you see the left lower pulmonary vein being injected? And you see that there is a narrowing at the entry point of the left pulmonary vein into the left atrium. And you are confirming that with another view. Here we have taken a lateral view, and you're confirming that there is actually a stenosis where the lower pulmonary vein is entering into the left atrium. Similarly, for a right pulmonary vein, you start off with a AP view. What injection have we done here, which is different from the previous angio that I showed? Anybody?
You see, it's an RP injection. One person has written.
No, but
okay.
I said correctly, wedge injection.
Wedge injection.
Yes, it is a wedge. Yeah, it's a wedge injection. Whereas in the previous one, we have entered through the ASD into the pulmonary vein directly. Whereas in this angiogram, you see that we have gone through the pulmonary artery and taken a wedge angiogram to delineate the pulmonary vein. So initially the right pulmonary artery is filling, then the right pulmonary vein is filling. And we have taken one more view to delineate the right pulmonary vein entering the left atrium. There is a mild narrowing at the entry of the right pulmonary vein into the left atrium. This, I think it is very commonly asked in exam. That is why I kept this angiogram. So the view itself will give you a clue. We have taken the angiogram in AP view, which we hardly ever do in a to delineate any VSD or any
ventricle. We have got quite a few right answers here. CCTG is what most of them have written.
Yeah, okay, that's good. So AP view will give you a clue that the septum is vertical, and that usually happens in a corrected TGA. So you can see that the IVC is draining into the left ventricle. Left ventricle is getting connected to the pulmonary artery. So AV and VA discordance here. The aorta is going into the right ventricle. This is another aortic root angiogram. If anybody can tell me, it's a very unusual case. So if anybody can tell me what is being seen here, it's a post-op case. You can see the sternal wires. It's a post-op case. Another clue is this is also another switch baby. It was a 1.4 kg arterial switch, smallest baby that we have operated. Shall I go ahead?
I think quite a few clues were given already.
Yeah.
This is a difficult one, ma'am.
Yeah, it's difficult. It's difficult. So you can see the anastomotic site. There is mild narrowing here, but that is not the issue. So the issue is that there is a coronary ostial narrowing. You can see that actually both coronary ostia were narrowed. This baby we couldn't salvage. It was a 1.4 kg baby, and this baby came back after 6 months of switch with significant ventricular dysfunction due to coronary ostial narrowing. Anybody wants to try this?
Someone's an absent pulmonary valve.
And actually, the annulus is quite big, so it is not an absent pulmonary valve. In an absent pulmonary valve, the annulus will be very small. What I meant to show was that it is a very thick and dysplastic valve. You see that it is not at all doming, it is kind of stuck onto the annulus. The valve leaflets are not at all moving, and you see the thickness of the valve when compared to the previous one that I showed, where you had very thin, pliable doming valves. This valve is not at all doming. In fact, it is hardly moving. It's a very dyspulmonary valve. Now, coming on to some tracings. So some things that you need to check for in cath lab when you're doing procedures. So these are systemic artery traces from the same patient. Can anybody say what are the differences? It's quite simple that we see every day when we are doing procedures. We see this, we note this, and I mean, we should note this. It's a normal phenomenon.
They've written proximal aorta and femoral tracing.
Exactly. So this is peripheral augmentation that you're seeing. So it is not that the suddenly the tracing has changed. So this is from the ascending aorta, and the spiking is due to the peripheral augmentation. You see a nice dicrotic notch also in the peripheral artery. The difference is that it is due to pressure pulse transmission, and there is a pressure wave reflected from the periphery in a femoral artery trace. So again, just to look at some of the fallacies, the top steep one is the ascending aorta trace, and the smaller one is the femoral artery trace. Obviously, we are probably dealing with a coarctation of aorta. So what are the fallacies when you look at tracing from ascending aorta and femoral artery in a coarctation of aorta? in this tracing, what are the fallacies? So you see there is a big gradient. So is it correct, or is there something that you should think of? Shall I go ahead, or?
No, we didn't get any answers.
Okay, so there is a fling, catheter fling in the ascending aorta. You see this is so steep and narrow and it is looking abnormal. So then you should always suspect there is a catheter fling. Okay, you should get your catheter in a better stable position to avoid the fling. Also, when you if you don't take pull back and you depend on ascending aorta and femoral artery tracing in a coarctation, you should remember that there is always peripheral augmentation of the pressure in the peripheral artery tracing. So you are likely to underestimate the gradient if you are taking ascending aorta and femoral artery trace. Also, you are likely to overestimate if there is a fling of the ascending aortic catheter. So these are the two fallacies. Is it too tough? Can anybody analyze the right ventricle and femoral artery tracing in this patient? So this is right ventricle and femoral artery tracing. So the pressures are nearly identical. So we are dealing with.
Someone says it's a systemic right ventricle. Not sure.
Okay, but more common could be a systemic right ventricle. Okay, in a you mean like in a corrected TGA or a TGA? It could be a large VST. It could be a large VST with pulmonary hypertension, or it could be a VST with pulmonary stenosis, where you have nearly equal femoral artery and RV tracing. What is interesting is that, see what has happened after the VPC. There is a premature complex, and see what has happened to the right ventricular beat after that. There is hardly any change. So what do you expect in a normal RV versus what do you expect in a RV with a large VSD? So that was the point that I wanted to highlight here. So what do you expect in a normal RV after extrasystole, and what do you expect in an RV with a large VSD? So we all commonly speak about the Brockenborough-Braunwald phenomena, where you have augmentation of the ventricular complex of the LV after a post extrasystole. So what you should, what you start noticing when you do cath is, when you put an extrasystole in a normal left ventricle, you don't get post extrasystole potentiation of the ventricular beat in an LV. Whereas in an RV, in a normal RV, you're doing cath in a person in a normal RV. If you put a extrasystole, you have augmentation of the post extrasystolic beat. Okay, so RV and LV behave opposite to each other when you give a post extrasystole, normal LV and RV. But here, the RV is behaving like a normal LV. Why? Because it is connected by a large VST to the LV and it is behaving like a LV. So the explanation is quite detailed. I don't think I have the time to go through that, but maybe you should read up on that. It's very interesting. So if you see that there is no post extrasystolic potentiation of the RV, there is a large VST connecting the RV and the LV. Shall I go forward, or are there any questions?
No, please, can you give an explanation why the LV and RV differs?
Okay, so yeah, okay. So in a normal RV, when you give a post extrasystolic beat, there is a sudden fall in SVR, and because of the sudden fall in SVR, whatever the extrasystolic potentiation, the added volume that is being pumped out, it is able to be accommodated in the peripheral circulation. That does not happen if there is a LV outflow tract obstruction, whether it is fixed or dynamic. So in aortic stenosis and in hypertrophic obstructive cardiomyopathy, this accommodation into the peripheral system does not happen. So there is extrasystolic potentiation. But in a normal LV, it is accommodated because SVR suddenly falls after a post-extrasystolic beat. What happens if you give the same beat to an RV? The pulmonary arteries are already, it is so compliant that it is unable to accommodate any further increase in volume. So there is a potentiation of the beat in an RV when you give an extrasystole, whereas it does not happen in a LV. So it behaves differently. RV and LV behaves differently. That is the explanation. It is very, very nicely described in a very old article where they have studied a lot of patients with normal RV and LV, and they have given extrasystoles, and they have found that this is the reason. Shall I go forward or?
Yeah, I think you can go.
Okay. Again, you see RV, there are two RV tracings. Both are systemic or even suprasystemic. But the tracings are very different in both of them. So can anybody say what is the difference between tracing 1 and tracing 2? Anand, shall I go forward or?
They just wrote that second one, sharp peak is seen. So
yes. Yes. Okay. So that is the morphology, the characteristic of the wave. That is what I wanted you to notice. So if you see the first one, it has got a rounded peak which resembles very much like a LV. So LV is rounded and usually RV is more peaked or triangular shape. So here it is. Sir? Anna?
No, I was just, yeah.
So here RV is probably connected to the LV via large VST, and it is. Yeah, so it is connected to the LV by a large VST, and so it is behaving like an LV trace, whereas here there is no VST, but the RV is under high pressure. So likely it is a severe pulmonary stenosis with intact ventricular septum. It's an inverted V configuration. Okay, this is quite simple. I just wanted to. So this is a aortic trace. What are the differential diagnoses?
you've written supravalvular AS.
Yes, that is one differential diagnosis, but much more common than supravalvular AS is quite uncommon.
They already
Anything
mentioned
more
about
common?
coarctation.
Okay, coarctation. Okay, so coarctation is the thing that should come first in the differential diagnosis. Supravalvular AS is a little bit more uncommon. Next, this is a difficult tracing. So this is a pulmonary artery to RV pullback. So the first part is pulmonary artery, and this is a pullback. I had to merge the two because they were taken at two different times. So this part is the pulmonary artery tracing. This is a pullback. So what are the findings? It's I can give another clue. This is a post-arterial switch, and the child came back with some complication after a post-arterial switch. The child is 8 years old. So this is a PA to RV pullback. And I can give another clue. These three beats are different from these three beats.
Neo-PS, someone has written.
Neo-PS. Bit more specific. So if you notice, these three beats are different from these three beats. That is a clue. Shall I discuss?
Yeah, I think we're not getting any answers.
Okay. So this is the pulmonary artery tracing. And when you pull back, these beads, you have to notice that these are the venturi. So this happens when a catheter is passing through an obstruction. So what are the characteristics of a venturi? The systole is same as the bead prior. You have a concavity in the systolic part. Then the diastole dips very far below the from the previous bead. So you have a same systolic peak. You have a concavity in the systole, and then you have a diastole that dips very low down. So that these are the characteristics of the venturi. And after the venturi, what you see is suddenly the systolic pressure has gone up. But what has happened to the diastolic pressure? It is still remaining the same. So it is not touching baseline. And if you look carefully, you see a dicrotic notch. So by all these clues, you realize that you have not yet reached the RV. So from a distal PA, you have come to a proximal PA, which is high pressure. So you're dealing with a peripheral pulmonary stenosis or a MPA stenosis, which is obviously the case because this is a post-arterial switch and you probably have a anastomotic site narrowing. Then the last three beat, you have come from the proximal PA into the right ventricle. So how would you identify this as right ventricle? Is that now the dip diastole is touching near zero. You have an end diastole and then the RV peak. So RV systole corresponds to the proximal high pressure PA chamber, but the diastole falls below that of the proximal PA chamber. So this is a proximal PA stenosis.
Deepa,
this, I think almost exact same figure is given in Moss Adam, madam.
Yeah, Deepa, I have the same doubt actually. If you see these both the tracings, hardly any difference because if they could be elevated right ventricular end diastolic pressure also. So you are saying the dicrotic notch.
Yes.
Is there any other differences like to really distinguish?
Yes, ma'am. Diastole actually is come down. Diastole is actually come down. Diastole is 10 in these three beats, but here it is almost like coming towards zero in the last three beats.
So you still have the ventricularization. Yeah. So I think that's.
So dicrotic notch you can see in the descending limb of the PA, whereas you see the A wave in the ascending limb of the RV. So these are the two clues. In fact, nearly identical tracing is given in Moss Adams in the peripheral PS section. So I think it's very nicely described in Moss Adams that almost identical image is given in that. Shall I go forward, madam?
Yes, madam.
So I thought I'll just quickly sum up on, I just have 10 more minutes. So just quickly sum up on some of the hemodynamics that we do in cath lab. So how do we detect a left to right shunt? Any single sample, 7% step up from SVC to RA, or a 5% step up from RA to RV, or a 4 to 5% step up from RV to PA qualifies for a left to right shunt, and a step down from PV to LA or LV to systemic artery counts as a step down of 3%. So this is I think most of you know that these are the formulae that we use to calculate QP, QS, effective pulmonary blood flow, effective systemic blood flow, left to right shunt. These are the formulae that we use. And so just a very simple example. Can anybody, very simple example, it's a left to right shunt. Can anybody identify where the shunt is?
Atrial level, they say.
Okay. One is at the atrial level. Anything? Any other abnormality? Is there any step up anywhere else? So you have a further step up from RA to RV as well. So it should not be taken up by just one step up. We should always continue to see if there is any further step up from in any of the chambers. So here you have a 10% step up from mixed venous to right atrium, signifying a atrial level shunt. We have a further 10% step up from RA to RV, signifying a ventricular level shunt. So this patient probably has a ASD as well as a VSD. I just put some questions. I don't know if it is little tough. So this was a 9-month-old child who underwent a palliative procedure on day 40 of life. So underwent a palliative procedure day 40 of life and suddenly has come back now. Oh, I've written the answers as well. So so you see, the thing that you should notice when you have any CAT data of a cyanotic heart disease is what is happening to the aortic saturation. So there is aortic desaturation. Then you have to look at the PA saturation. See if the PA saturation is same, more than the aortic saturation or reduced. So here you find that it is somewhat lower than the aortic saturation. So if you have a PA saturation that is more than the aortic saturation, you are dealing with the transposition physiology. If you have the same saturation as that of the aorta, PA and aorta same, you're probably dealing with an admixture physiology. And if you have a PA lower saturation than the aorta, probably it is a reduced pulmonary blood flow situation. So now you have a probable diagnosis. You have a reduced pulmonary blood flow. Aortic saturation is 85%. Now you see what is happening to the, where is there any step up anywhere? So SVC saturation is 64. There is no step up at RA. There is no step up at RV. But there is a step up at PA. So you already have a clue that child has undergone a palliative procedure on day 40 of life. Then you have a step down from LA to LV. So what could be happening? From LA to LV, there is a step down. So there is probably a large ventricular septal defect that is streaming bidirectionally, causing some desaturation in the left ventricle. Now you look at the pressures. Pressures, right ventricle and the left ventricle are nearly same. And you have a huge gradient between 76 gradient between the right ventricle and the pulmonary artery, which signifies a pulmonary stenosis. So you put it all together, you have a large VSD shunting bidirectionally with a severe pulmonary stenosis, and you have some palliative procedure that is causing some saturation or hike in the PA. So that is probably a BT shunt. Any questions? Anand?
No questions yet.
Okay. So I think shall we
Someone wanted to
close
explain the effective pulmonary blood flow.
Effective pulmonary blood flow. Okay, shall I just go to the TJ slide then, madam, because it is very clear in a transposition physiology. So effective pulmonary blood flow is the deoxygenated blood that is going to the lungs for oxygenation. That is effective pulmonary blood flow. And effective systemic blood flow is the oxygenated blood that is going to the body without shunting. So if you see, so usually in normal people, the total pulmonary blood flow is actually the effective pulmonary blood flow, because whatever is going from the right atrium to the right ventricle is going to the pulmonary artery. There is no left to right or right to left shunting. So whatever is going through the pulmonary artery in a normal person is the effective pulmonary blood flow. Whereas if you have a left to right shunt, some of the blood, for example, you have a VSD. So some of the blood that goes to the pulmonary artery is shunted from the LV to the RV. That is already oxygenated blood that is going back to the pulmonary artery. So you have total pulmonary blood flow will be effective pulmonary blood flow that is coming from the right atrium, right ventricle to the pulmonary artery, plus the left to right shunt that is coming from the through the VSD from the left ventricle. Okay, so total pulmonary blood flow is any left to right shunt plus effective pulmonary blood flow. But in a normal person, total pulmonary blood flow is actually the effective pulmonary blood flow. So how does it differ in a TGA? If I can take 5 minutes, is it okay, madam? It's 8:27. Shall I just describe what is happening in a TGA or?
Yeah, I think go ahead. Yeah.
Yeah, that is important, because in all the shunts are also,
so
these people are asked to calculate the effective pulmonary blood flow, even to know the right to left shunts and everything also. So they wanted the explanation.
Okay. So what happens in a TGA is that the circulations are in parallel. So all the systemic venous return, all the deoxygenated blood goes right down back to the body, back to the aorta. And the pulmonary venous return, the oxygenated blood goes right back to the lungs. So it is not compatible with life. So for it to be compatible with life, there has to be admixture. So how does the admixture happen? When you have any shunt at the atrial level or ventricular level or the ductal level from the right system to the left system, now you can tell me what is happening. The deoxygenated blood, some of it is shunting through an AST or VST into the left system. So this is anatomically, it is a right to left shunt, but what is it actually providing? It is actually providing the effective pulmonary blood flow. So the term effective pulmonary blood flow is so very important in a TGA. So you have an anatomic right to left shunt that is providing the effective pulmonary blood flow in a TGA. Okay. So effective pulmonary blood flow in a TGA is the anatomic right to left shunt. So what is the effective systemic pulmonary blood flow? Whatever shunt is flowing from the left side of the heart to the body, to the aorta, that constitutes the anatomic left to right shunt, and that is the effective systemic pulmonary blood flow. It's a very difficult concept, but once you know this, you understand how important it is in a TGA to have adequate intercirculatory mixing, because you are not concerned with total pulmonary blood flow in a TGA. You are concerned with effective pulmonary blood flow, where you want the deoxygenated blood to go into the lung. You don't want the oxygenated blood to go into the lung. So you want to increase the deoxygenated blood that is going into the lung, and you want to increase the oxygenated blood going to the aorta. So you have to make sure that you have effective pulmonary blood flow as well as effective systemic blood flow in a TGA. And which is the best chamber for mixing in a TGA? That will provide both effective pulmonary blood flow as well as effective systemic blood flow. There has to be communications. So which communication is best?
Yeah, please say atrial level. Yeah.
Yes, it is at the atrial level, because at the atrial level there is not much pressure difference, and so the shunting is nearly equal in all cycles of the in all phases of the cardiac cycle, and you are not increasing the total pulmonary blood flow. Whereas if you have a large VSD as opposed to a large ASD, if you have a large VSD in a TGA, you are increasing effective pulmonary blood flow, but you are also increasing the total pulmonary blood flow. So much so that you can land in pulmonary edema in a TGA. So TGA with a large VSD will be in much more significant heart failure than a TGA with a large ASD. So TGA with a large ASD will be much more stable. Shall we stop here now, madam, and maybe take a...
No, what they wanted is the equation to calculate the effective pulmonary blood flow. Explain that. That's what they usually asked in the exam.
Okay. Yeah. So QP minus left to right shunt. QEP. This is a pulmonary venous oxygen minus mixed venous oxygen. That is the QEP.
Yeah, that equation they wanted the explanation.
Yeah, okay.
Because usually this is asked in all the left to right shunt cases.
So shall we stop here and maybe proceed in another class? It's already 1 hour.
Yeah, I think that is the best, and it is so nice. And all of us are also putting our brain to understand it. So it's very good.
Madam, we can have a feedback, like whether it should be more basic than this, or whether we should...
no, basic, always we start with the questions of the basic and everything, and we'll end up only talking about the basic. Yes. This type is better because each angio, but we have to take a little bit longer time than going a faster,
yes,
so we can understand in a much better way. And if it is required, we can divide as a 2-3 classes also. But this presentation is excellent. Of course, few of the questions are at the very higher level. They may not be asked for the DM level, probably for the pediatric cardiologist they will ask, but it is worth discussing the concept. That is the most important. Anyone want to add any comments?
Anand sir or Snehal ma'am?
Oh no, I think that was quite exhaustive what Deepa did, and especially some of the pressure tracings, highlighting what happens in the peripheral PS, the pullback, where you try to analyze the diachrotic notch. I think all that were subtle things which most of us would not notice. So I think it's important for the students in training to analyze all this. Yeah, but I think we need to have some more sessions.
Yeah.
And yeah.
Maybe I should tone down. I think we should start a little bit more basic, and then I don't know my audience whether they are pediatric cardiologists or
Adult and pediatric postgraduate students are the target audience now.
okay.
So I think that it's fine. I think they should be. It's good that we are aware of such things, because I think in a lot of event centers they may not have exposure to pediatric cardiology. So I think that's where we need to fill in the gap. So I think it's fair.
Thank you, Dr. Deepa. It was really exhaustive and wonderful to have you. Soumya, go ahead and conclude.
I really thank Deepa madam for such a great session. All of us have learned a lot, and Dr. Anand and Dr. Snehal for moderating it and keeping all the audience and taking care of all their answers, trying to tell Deepa ma'am and everything. Truly, we enjoyed. It was a very great session. As everybody said, we would try to do another session in this year again on pediatric cardiac catheterization and the hemodynamic tracings and oximetry runs. Thank you, everyone. It was a great session, and we had 91 participants. I've never seen so many students logging in for one session. Thank you, everyone.
Thank you.
Thanks.
Thank you. Bye.
Bye.
Bye. Thank you.
Thank you, sir.
Thank you. Bye.